Good morning, everyone, to this webinar on digital as an enabler of quality service. We're just going to wait a couple of minutes for more people to join, and then we will get going. So, good morning, everyone. I'm sure a few more people will appear as we go along, but let's make a start. Welcome to this Maldaba webinar on the question of digital as an enabler of quality service. Thank you all for coming today. Maldaba are recording this webinar, and that will be made publicly available on YouTube in due course, so bear that in mind. I'm your chair for today. I am Dr. Henry Potts. I'm a Professor of Health Informatics at University College London in the Institute of Health Informatics. So I study the development, evaluation, regulation and implementation of digital health in a wide variety of contexts. What we're going to do today is we're going to go around, meet the panel for today, discuss the question for about 40 minutes, and then there'll be plenty of time for audience questions as well. Audience, with your questions, please put them into the chat, and then we will ask them at the end. So, if everyone's okay, let's get going. What I'd like to do is to ask each member of the panel to introduce themselves, explain where they come from, their background, why they're interested in this topic, and also to, just as an introductory question, explain what they consider to be a quality service. What do those words mean? What is quality in the context of digital health? So I'm going to start with Dr. James Somauroo. James.
Thanks, Henry. Excuse me. So I'm battling a head cold at the minute, so apologies if I sound a bit bunged up. But yes, hi everybody, my name's James. I am an anaesthetics and intensive care doctor by background, so I practiced clinically for 5 years. I've done lots of different things in leadership, policy, innovation in the NHS and wider commercial health sector. So I've worked at NHS England, Health Education England, the BMJ, and I've run a couple of health tech accelerators helping startups, digital health startups to be specific. Other side of my life has always been media, so I write for Forbes on health tech as a contributor. I host something called the Health Tech Podcast. We've got a news brand called Health Tech Pigeon. That's a podcast and a newsletter. And I'm co-founder CEO of SomX, and we are a communications and creative agency for health tech, biotech, and broader healthcare companies. In terms of quality, when it comes to digital, it's a really interesting question, and I'll be brief to begin with because I know we're going to go into this in detail. But I think quality has to relate in part to improve patient outcomes. It has to relate in part to operational efficiency, and it has to relate in part to cost effectiveness as well. A quality service really has to have all three of those things. It's just that my experience seems to be that we focus on the latter two, the operational efficiency and the cost effectiveness, rather than putting significant enough weighting on actually the quality of service as felt by the patients. And I mean their experience of it, not necessarily just the binary result. But I can go into more detail on that later on.
Thanks, James. Let's move to Professor Cook. Tell us about yourself.
Good morning, everyone. I'm Glenda Cook. I'm Professor of Gerontological Nursing at Northumbria University, and I lead a research group called Better Living in Later Life. So we have a number of strands to our research, but so in this context, so two strands of particular interest. One, we look at tech-enabled care, what that is, what older people and their carers and the supporters want and what they need, and so also working with the tech developers and the product developers about innovation, about how do they actually implement those within a service context. So we do a lot of work in terms of service transformation and service innovation. The other strand that we're very keen on is working with the workforce. There is an understanding that the workforce will just adopt and use this technology, but that's not necessarily the case, that they have the level of competency to do so. So we have a strand of our work that's looking at enhancing that competency. In terms of sort of quality of and those markers of a quality service, with respect to tech-enabled care, I think the things that really come to my mind is about that technical efficiency, the reliability that the products and services will do what they say they will do when it is needed, so absolutely reliable, the speed and the accuracy. But the other side of a service is thinking about use of the users, reception of that service, about sort of the empathy with their conditions, the responsiveness, and importantly, how does that tech actually improve the quality of their life, not necessarily just about the quantity and the service delivery, but that quality of life, so the outcome for them from a quality perspective.
Thanks, Glenda. Tom, tell us about yourself and your interest in this area.
Good morning, everyone. I'm so delighted to be here. I left medical school very early when I realised, and I was in Manchester at the time, that maybe, which clinical setting you were working with was a much, much bigger determinant of the quality of the service rather than which human doctor was there doing the job. So I thought no matter how hard I tried, how much I got ahead, how much I cared about my patients, if I was in a trust service that was a mess, it wouldn't matter, because it's how the team adds up to care for the patient. And that's taken me on a journey. So I then went into management, transformation and policy. I did theatres and outpatient transformation across various trusts, and then went and worked in some regulators. And then I found my passion working with clinicians to redesign services and work with managers to redesign services in Oxfordshire as a quality manager, and then as leading a small commissioning team. And it was here where the light bulb moments happened around digital as an enabler of quality service. So quality is what I'm here for. It's why I'm in the NHS. And I'd understand it in a similar way to the other panelists. I think the official, way of the NHS understands quality is often around safety, around patient experience, and then around patient outcomes. But I think thinking about experience, we need to think about the experience of the care team too. Because if the care team is having a good experience of delivering, then they are much more likely to be in the emotional states, to have that bedside manner, to have that emotional intelligence, and to improve that patient experience. So I've got like another layer of quality that I've picked up over the years. You want the workflows to be intuitive, so you don't have so much cognitive dissonance around, what am I doing next? And then that really frees up your mind and your heart to think about what to do next for the patient. You want to be in a solid team where everyone's got each other's backs. I think that's really important for quality, and it's easy to communicate. And then to have complete data. So if you're only working on half the information, how are you going to make the right diagnosis? How are you going to make the right treatment? If you've only got half the data for what to use in terms of treatment, or if you don't have the resources to deliver the right treatment, you're not going to get the right outcomes. So there's that extra layer of quality too. And I've ended up in technology as a full-time job because it has been the most effective way that I have found so far of achieving quality in our NHS. And I'm delighted to be speaking to you from Clatterbridge Cancer Centre, where I've found a great group of people to do that with. So yeah, good morning.
And finally, Lorenzo.
Thanks, Henry. Thanks, everybody, and good morning, and thanks everyone for attending, and especially thanks to the panel. Delighted to have you all with us, and Henry chairing. As many of you will know, I'm a co-founder and director of Maldaba. We're a relatively small software development and digital agency using web and mobile technology based in London to help and support and improve things in the public and not-for-profit sectors. And although we're small, we've been around for quite a while. We started the company, me and a school friend, in 2002. So I've been doing this for quite a long time, and often kind of really driven and motivated by trying to make people's lives better, whether that is patients or staff working in often quite large organisations such as exist in the NHS. And although I'm not clinical, I don't have that background. I've kind of always been interested more on the techie side. I grew up in a family of doctors, and so it was very common for us to sort of have conversations when I was younger about what was the role of medicine and quality versus quantity, about is it around making people's lives better versus just extending people's lives because you can. And I've kind of taken those principles and those ideas into what we do in technology. So to bring it round to the question that you pose, Henry, for me, a quality service is something that improves something ultimately for the patient. That's kind of the end goal. But in order to get there, you have to improve things for lots of other people as well, such as frontline staff, nurses, doctors, managers, administrators, all of those people. And technology is often what I kind of call the tail that wags the dog, because in order to do that, you often need to then make other changes, either in the way that workflows are designed, or the way that people access information, or the way that people interact with one another in order to bring about those changes. And that's kind of what we really care about, is how do we make those things better? I think the one thing that technology isn't in this regard is about replacing people. For me, that's absolutely not the role of technology. Technology is an enabler. It is at best a tool. And either that's around improving the way people work by augmenting existing services, or it's around improving the way people work by changing services in order to bring about the impact that we all want to see. But it's always about supporting people in order to do the best that they can to bring about what I think is generally a shared outcome, which is making patients' lives better.
Thanks, Lorenzo. We thought we might start this webinar with some myth busting, and with this question of whether there are any misconceptions people might have about how we can use digital tools to deliver an enhanced quality of service. So I'm going to put that question to the panel, starting with Glenda.
Oh, thank you, Henry. A big question to start with. Yes, as much of my work has focused on older people, their carers and their supporters, I'll probably draw heavily on those examples. But I think for me, the quick response to that question is that for older people and their carers, they can't use the tech. They don't want to use the tech. and the tech's sort of not appropriate for them, and they won't won't use it in the circumstances by which the tech within a health and care context is prescribed. And I think that's where some of the myth busting starts, is thinking about our patient population or client populations, is that you're rethinking, well, what do they want to use the tech for? And in my experience, if we get that answer correct, people will use the tech as long as it's the right tech, and it's developed in such a way that it's suitable for people to use. So I'll give a couple of examples. You're drawing from young people with learning disabilities. We wanted to look at what everyday tech products could they use in a care context to enable them to be as independent as possible. So we ran a number of workshops where they came to a house that we'd been given for a year to test tech products, and so we had groups of young people, with their carers and supporters, come in, just have a look at the tech. And one of the tech products that we exposed them to was an Alexa. And the young people asked the men, what do they want to do? And the young men would say, I don't want my carer to give the football results. They're avid sort of football supporters. I don't want the carer to do it. I want to find the football results for myself. And one young man said, well, if you use this wake up command and you ask Alexa, so the football results will come up. And he did that. And all afternoon, he overrode our conversations, and he had absolute enjoyment by keep going back to the Alexa and asking for football results. Another young man in the same group, unfortunately, had communication difficulties, and he could not pronounce the wake up command that would respond to him. So rather than say Alexa, he would say Aletha. And it would not respond. So the frustration and anxiety, and his carers said, we'll do it for you, but he wanted to do it for himself. So we had a very talented computer programmer who was working with us, and we had smart buttons. So we had a range of other things. So with him, she said, well, can you press these smart buttons? So what football teams? So you had 3 different color smart buttons that could communicate, because you programmed it to communicate with the smart speaker. And he just pressed the green for his football team that he wanted, and another team. He absolutely enjoyed that. And the level of independence might seem a small thing, there's small examples, but for these young people, that level of independence was very big to their quality of life. And you could program it to do a range of other things. So, so I think that is a nice example of demonstrating a number of myths that so these young people could not use the tech. Of course they could use the tech. Could they use it in the way it was presented? One person could, another one could not. So we had to change that interface by which they communicate with their tech, and the outcomes was an improvement for their quality of life. Another brief example before I stop talking would be people with dementia. Equally, often hear in my work that they will not be able to use the tech. And again, I would just say that absolute rubbish. Again, it's about, have you got the right tech to address the need or the expectations of those individuals? But there's a range of difficulties, because often our tech products require people to be able to interact in a particular way. So people with dementia, cognitive difficulties, might not be able to communicate with the product, but equally they might not be able to remember the commands that they have to do, or the syntax tends to be very quick, complex syntax, so they might not ask the questions in the right way. So I think my plea would be for developers to do like a lot of co-production with people and find out how can they use the tech and for what purpose, and so then they will adopt it. The other thing that I would say is equally working with the workforce. Absolutely critical. Again, there are lots of myths around the workforce about their competency to use tech in what circumstance. And so a brief example there would be if the tech requires additional work in very busy work lives, or it duplicates work. So they might be very enthusiastic to try it out, but will they adopt it as routine? Probably not. So there's a huge range of issues that I just want to throw into the discussion as an opener.
Thanks, Glenda. Would anyone else like to jump in on myths they want busted around how we can use digital?
I actually have a question for Tom related to this, something that Tom said in his introduction, and that was about staff. I think there's a myth going around at the minute that artificial intelligence and machine learning are going to save us all, and it's going to save staff, and it's going to save time, and it's going to save everything. Co-pilots are going to listen in the background. All meanwhile, anyone that's worked on the ground floor of the NHS will know that it takes 7.5 minutes for their computer to start in the morning before they can even write a discharge summary or different things along these lines. I know that people building tech who want to increase quality, they want to create better services, they want to help staff, they do, and they're trying to think of ideas. But I think, and this might not be a myth, this might be true, but I'd be interested in your opinion, Tom. Can you build a business model around helping staff? And to give you a little bit of context, I remember once as a bright-eyed, bushy-tailed junior doctor, I came up with an idea that could save an hour of doctor's time per day. And I remember speaking to someone in finance who said, great, I need to sack 1 in 24 of you to actually get that money back on the P&L in order to create a day, 24 hours in a day, etc. So do you want me to sack 1 in 24? So people struggle to build a business model to actually bring a piece of tech in to actually make staff lives better. But as you quite rightly point out, happy staff means a better quality service. Can you build a business model around helping staff out? Is that possible? Can you build a tech company on that premise?
I don't know, because I haven't built a tech company before, is the very short answer. I think any tech company
can you
selling
justify buying a product that just helps staff then? That's probably a better question.
Yeah, we do. We do. I think we've even got I don't know if it's AI powered, but we've got some kind of digital mental health app available to our staff. The NHS nationally has bought Headspace. There's all sorts that can be done there. I think that's absolutely possible, and certainly I don't think I'm ever going to make any money from it. But I've got a voluntary group that I run in my spare time called the Clinical Digital Manifesto. And this is about working with jobbing clinicians and jobbing managers and jobbing digital people in NHS providers to really come together around, why is it that some people's computers are taking 7.5 minutes to load up in the morning? Because it could be the connectivity. It could be wonky devices. It could be the IT support's got the plugging wrong. It could be you're on an old Citrix version that doesn't work with an EPR. It could be the EPR itself. Like it's quite hard to investigate what's underneath those day-to-day gripes with IT. I'd call all that IT. And that brings me to, in answer, yeah, I think it's possible. No, I don't think it's ever easy to do a tech company into the NHS. So if that makes sense, so that brings me to my main myth. My main myth is that you cannot treat digital like an IT service. And that's what we're doing. We've got the same sorts of roles, the same sorts of skills, the same sorts of ways of working, but we've rebranded IM&T digital. To be truly digital and to really get the benefits, we can't just accept programs that are helicoptered in from above from a policy wonk who hasn't spent a minute in a service in the front line. We need to be steeped in the problems of our care teams. We need to know what user design means. We need to go and speak to our patients like Glenda's been doing and learn from that research and build that into our projects. We need to focus much more on figuring out what's the right thing to do and how, like what's out there in the market. I hear all the time, oh, we can't do that. Oh, digital can't, oh, they've looked at that. Oh, it's too hard. Oh, the supplier said no. And it's almost like we've forgotten that the whole world has gone on this massive technology boom for the last 20 years. And the stuff that we're looking at in the market now, the capability of, how to code, how to do front-end design, how to do back-end engineering, how to use multi-cloud, people are talking as if that doesn't exist. We are the land that design forgot, and we are the land that technology forgot. And there's a whole new skill set, there's a whole new generation that at some point the NHS will adopt. and will be more than just a relabeling of an IT department. We will build, by hook or by crook, we will build that digital capability, and it will be great for people. And that we can't do it, that myth will die, because it's a myth. It's not true.
Are they what's stopping it?
Interesting question. I'll refer back to the chair for the next segment. Need some time to think about that one.
So picking up on those themes, so several people have already mentioned this question of how digital innovation fits in with how the whole system works, how the workforce works. So on the one hand, we have the idea that it's important to understand existing pathways in clinical care and how people work. And if you're going to introduce a digital system, you need to understand how it works and make sure your system fits into that flow, because if it doesn't, it's not going to get adopted. But maybe also we have this idea that we need more revolutionary change, that sometimes we need to completely change what the workflow is in some more dramatic way, rather than fitting our digital into the existing workflow, although that might be more difficult. So I'd like to start with, well, come back to Tom. Maybe you could expand on what your thoughts are on that challenge.
So this is where I believe in the design skill set, right? So in government, you've probably got teams that are a bit too big for us locally, in that you've got a user researcher and a junior user researcher and a designer and a junior designer, and then a lead dev. And those 5 people will go and speak to loads and loads and loads of users, and they'll then think, okay, how do we build this thing based on what the needs are, and really peel back the layers of the onion to go, okay, they said this, but what do they mean? What do they really mean? What do they really mean? Okay, what they really mean then goes out the water completely, because we've got an MVP, we've got a wireframe, we're working with it, and we're really seeing how do they respond in practice. And that skill set helps you understand how to build something that's going to be transformational, something that's going to really change how someone responds in their environment to the task they have, their objectives, who they work with, the information they look at, how they coordinate. And when you take that into a busy, highly regulated, challenging situation where you've got lots of variation, you can't predict what your next patient's going to be. We don't follow a pattern in the NHS, right? Why one person gets sepsis and another does, one person gets a pressure sore and another does. We know that there are some correlations, but there's still a huge element of uncertainty in everything we do. So how do we translate? Like, it's much harder to bring that skill set to the NHS than it is to do a government website. It just is. Government websites are kind of fine. They're kind of easy. If we try and enable a care team to look after someone who has a biopsychosocial makeup that's really hard to get to the bottom of, that's a much, much bigger challenge. And that's where we need to find new ways of working, where we're putting the care team and the patients in the design process. I think it's possible. I haven't seen it being done very, very, very well easily in the NHS, and I think some of that is around mindset. It's almost hard to work with that blank sheet of paper if we have been working in these deep grooves of, well, I always do this sheet. I always assess these 5 things. This is an internationally validated tool from 20 years ago. NICE says this, so there's lots and lots and lots of constraints built into how we work. And that then means that the design game is also constrained. So yes, we can do that. And I think in EPR programs, you're forced to, right? If you're doing an EPR program well, one of the myths, by the way, is that it improves productivity. It does for a few trusts, but on the whole, it goes the other direction. If you're doing an EPR program well, you've got the whole care team engaged in how are we going to work really differently with this new tool that's going to be our clinical system. And you have an opportunity to use the kind of business analysis tools of, here's what we're doing as is, here are our pain points, here's where we're missing things as a team, and you can actually get the Sharpies out and the Post-its out, and you can start brown papering with the whole care team. Here's how we want to work, here's our future pathway. The bit that we haven't quite got yet is a fully responsive market that will go exactly where the care team wants to go. So we're a little bit constrained in terms of incumbent supplier instincts and ways of working. We're a little bit constrained in terms of mindset in our teams. We're a bit constrained in terms of skill sets and resource to do the design in the first place. But it's absolutely possible, and it's wonderful when it does happen. I think one example is, during COVID, and this is really hard to engage people, right? I was working at NHSX and I was chatting to my old friends in the stroke unit in Oxford, and they were talking about how challenging it was, how late people were coming in with stroke, and wouldn't it be wonderful if they could just get a scan from anywhere, see it on their phones, and then make a thrombolysis decision so that they didn't have to get brought into the hyperacute stroke unit. That then meant that we went and looked at AI solutions around the world. We created a new framework. We rolled out Brainomics and Rapid AI and Viz AI, and that's now in use in 80% of hospitals. That was quite quick. That's a completely new care model where we've got a stroke consultant deciding on thrombolysis from their bed. And that's much better. It's much better they're doing that from their bed or wherever they are, or skiing or whatever, than having to go into the hospital, right? It's much, much better for the patient because they get that treatment so much quicker. So it's absolutely possible to think big with technology. And that pathway means the patient's going somewhere different. We're upskilling a minor injury unit or whatever to do a CT head. We are, using AI to guide a clinical decision. We're using mobile technology. We're using, virtual provider networks differently. We had to take that through IG governance in different ways. So it's when you've got that clinical alignment, that's almost your fuel for change. If you don't have that clinical use case, if you don't have that vision, that outcome that you're going for, does digital ever work? Do you just get stuck in governance? You need something to pull it through. So I think that's absolutely right. If we focus on those bigger transformations, and we focus our limited time on where's the energy, where's the clinical buy-in, where are the priorities for our patients, then I think digital becomes a lot easier and a lot more intuitive.
Can I
come in,
Sorry,
Lorenzo?
I was just going to respond to some of what Tom said and respond to your question on it, Henry, which is my take is to remove the word digital from digital innovation. Can we talk about innovation holistically, not automatically silo it in terms of digital? Yes, obviously we're here to talk about digital, and I'm coming to you from a digital firm. But if what you want to do is have that impactful change, then you need a holistic view on it, and you need to look at innovation in a completely holistic digital and non-digital view about what are you going to change and how are you going to approach that, and where does digital help? So, for example, all of this year and most of last year, we were working on and launched a new solution, annual health checks for primary care, to support the role of GPs and their staff in primary care carrying out annual health checks for people with a learning disability. And when we started looking at some of the reasons why this doesn't happen, it's got nothing to do with technology. It's about the approach of how GPs who have got way too much to do and are being asked to do more are approaching the whole issue of annual health checks, and how that's perceived by families, by patients, by community care, social carers who are required to support in order to get these things done. And so we did take that completely holistic view, and we did all of the co-design and co-production work that Tom was talking about, but we extended all of that into redesigning with staff and with patients and with community care what is the standard operating procedure for carrying out annual health checks in the full 12-month cycle, regardless of which technology or any technology, because the SOP that we redesigned works just as well, and we did this deliberately, if you're working off paper. Because the idea is, actually, we want everyone to benefit from improved access to annual health checks, because we know that the benefits for patients are that they are less likely to die 20 years earlier, as is the norm with people with learning disabilities from the general population, if some of these issues can be caught earlier. So our view wasn't, let's design a whizzy app because we can. I mean, we did, and it is whizzy and it's great, but that's just a byproduct of looking at the entire SOP through the whole 12-month process, about saying, how can we help use this opportunity to redesign it so that it works better, more efficiently for primary care, it works better and improves the relationship with social care, and it gives patients what they want. And yeah, there are bits of technology in there, but the SOP, as I've said, works regardless of that. And I think the implicit silo in the words of saying, well, we're talking about digital innovation, doesn't help us as a community, as a culture. And to say, well, let's talk about innovation, let's talk about what needs to change, and let's take a step back and look at that in the broadest possible sense, and then let's work out where can digital technology help with that by making things better. So in our case, it means that, for example, the pre-annual health check questionnaire can be done online in an easy read version, so you get around some of the challenges of them not being posted back or not being received in the first place. The health action plan, which comes at the end of the appointment, now can go into an interactive app, so that makes sure that more patients with a learning disability actually receive the health action plan at the end of the process and can interact with it digitally, and that information can flow straight back to the GP so that they know what they're doing for the review. Those are really handy tools, but they're not the change. The change is the change in perception and the way that one approaches the whole 12-month cycle of the annual health check.
Can I be really cheeky? James asked me a question. What's standing in the way of this? You know, we have abundant and incredibly potent technologies and market actors, a very vibrant ecosystem now. We've got, 5 panelists that are all quite violently agreeing that we need to design with the patient and the care team in the middle. I want to throw the question back to you, Henry, with your academic hat on, and Glenda as well. You've had a bit more time to sit back and analyse this and write papers and work with people from that perspective. What do you think is stopping the NHS from doing this stuff, from getting people around the table, designing from first principles, appraising the market, managing suppliers well, and off we go?
Well, I think that's a huge question, and I'll be nice to Glenda and give her time Henry. To think about it while I come up with some answer. I mean, I think health is a high reliability sector. It is, we can get things wrong. There's a huge amount of iatrogenic damage done by the healthcare system to patients, so we have to be very careful about things, and that requires careful consideration of safety and evaluation. At the same time, I also think there's a lot that comes down to 2 issues. One is organizational structures of who pays. How is it commissioned? So within the current NHS in England, very little is commissioned nationally. Everything is commissioned at a lower level, and I'm not certain that works very well. Individual trusts or groups in primary care don't necessarily have the expertise to know what they should be commissioning. It's very difficult for digital health companies to sell into the NHS, because you're actually having to sell into large numbers of different bodies. You're not just selling once. And that creates a huge amount of problems. And I think there's also challenges around the workforce. The workforce are exceedingly skilled and knowledgeable about healthcare, but that doesn't mean they necessarily know about digital and what digital can do. And there's a big challenge around how we bridge those gaps between people very excited about digital outside the system, who are often very ignorant about the details of how workflows work, and people within the system who don't necessarily understand everything digital can do. I mean, there's a lot of brilliant people, including here on the call, who are good at bridging these gaps. But you have a very complex system, as Tom described, which doesn't necessarily have the capacity for innovation because it has a huge amount of work. It's not necessarily very well funded. It's just trying to do the day-to-day stuff. There isn't the capacity to then think about major innovation. And there aren't necessarily the skills, I would suggest. What
about incentive, Henry? Do you think there are incentives in the system to innovate? Is there an incentive to go out of your way to research, build up your skill, learn to critically appraise the technology market, and then to bring it in? Or is there too much personal risk on that individual to do so?
I mean, I think there are some incentives in some ways, and there aren't in other ways. The big incentive for a lot of the system at the moment is cost saving. If you can come along and say, I can save costs, you've got a much higher chance of being commissioned. If you can come along and say, I can make things better at a slight increased cost, that should be a good thing, but that's a much harder sell.
Can I give one example of that from our trust, Henry, just to give you a moment? So we have this incredible manager from our radiotherapy services who has tirelessly collected data, worked with partners across our ICS, and championed this group of patients that gets a complication from cancer called metastatic spinal cord compression. This is when one of your parts of your tumor, usually from breast, lung, or urological cancers, ends up in your spine, and it grows and it impinges on your spinal column, and that leaves you with often, very, very extensive handicaps and challenges. And we've worked with this patient group and across all of our secondary care providers, and to identify them early, get them in radiotherapy as soon as possible, put stabilizing SACT in place. We've even done like innovations around this patient cohort, like ways that we can do a tablet holder so that they can communicate while on a bed, and special ways of drinking. We would like to sell how to do this to the rest of the NHS. The NICE are behind us. NICE have written up this pathway that we've got. We've helped them to systematize what we've done to do it as efficiently as possible. And we've extended people's lives by 7 months. It's quite a lot, right? And it's, 7 months of life in a couple of years, and we're getting better and better. The NHS doesn't really want to bite, because actually 7 months more of a disabled group is cost. And I find that a real heart sink. We're doing our job well, but we almost need to use these big national levers before the NHS will put budget aside because of the way that it works. So, yeah, I think we don't have the right incentives for digital as an enabler of quality service. Like you said right at the beginning, James, we've got it for the cost effectiveness, but it's very hard. It's people's goodwill. It's people sticking their head above the parapet, like this fantastic manager in our trust, and doing things despite the system because they're so well motivated, that leads to real service quality through digital. And I don't know how we change that story, really. We do have enough money to be bold and to be ambitious and to deliver a quality service. We do have the talent. We do have the will. We do have the values. But there's something just not quite clicking as a system. And I'm not sure I can put my finger on it. But everything that you mentioned, Henry, plays out in our trust internally, right? Like, we have strong governance. It takes a long time to agree what we do for all those reasons. So I don't know if that was helpful as a little example where it's a really hard sell, even if you're doing what healthcare is supposed to do on the tin of improving quality of life and life expectancy.
So I want to come to Glenda.
Just
one
add a few
moment.
points into the discussion. I think there's issues around short-termism. The NHS jumps with a political mood, and so what's a priority changes with that political mood. Short-termism in terms of funding, so also becomes a barrier. Bureaucracy, so I would throw that in as some substantive bureaucracy that can get in the way. And boundaries between health and social care. So I'll just wrap those 3 points into an example. I was involved in an evaluation of long COVID service in one of our services in the Northeast. And there was a real willingness, yes, of, if you can remember back to that time in the pandemic, years of it, you had the acute phase, and then all of a sudden these years of young, seemingly healthy people weren't recovering, people with complex problems, so that it really was, quite a scary time. Now these people required the input of a range of specialists, so the cardiologist needed information at hand immediately, so the psychiatrists needed that for all the mental health problems that went alongside it, the respiratory physicians, and they needed all to be working together, but they need to be working together with our voluntary services. In the community, people were shut off, couldn't get the care services in. They need to be working with industry, so how people in these awful conditions, could not get out to the shops to get anything to eat. So they had nutritional problems. They need to work with a dietitian because of all the problems with unable to smell, eat. So their relationship with food and drink changed enormously. And then with social care, and what we found in our evaluation. I won't go into the details of it, but what we found in the evaluation is that there was a real willingness to work with the digital teams, that immediately these health professionals who needed immediate access for the clinical support and the decision making to talk with each other. So they had pathways that were brought in digitally to enable them in a virtual space to have multidisciplinary conversations. The data was there immediately. So the patient information, there was, that the boundaries that existed between primary and acute care and specialist services, tertiary services, so they were broken down. The information flowed with the patient, and you got good, effective outcomes for the patient because it was very complex problem decision making that no one consultant or expert had the answer. They had to work together. But where it fell down is that boundary between health and social care. So that the information didn't flow to social care. So the discharge arrangements falling down, that people didn't have their equipment at home, they didn't have the services going to their home. So on the one hand, our digital pathways worked, and this was it was bespoke pilot. The transformation led to really good patient outcomes, but again, that was not sustained or scaled up in the NHS. So we had that local learning not sort of filtering through the rest of the NHS, where you could have that scalability and that transformation going on across all the services who are facing the same types of problems. So I'm just throwing into the discussion that there are substantive issues alongside the other issues that we've already discussed, just to throw a different spin on it, Henry.
Thanks, Glenda. I think that's really interesting.
I could also add a dose of optimism if that's useful at this point.
Yes, can I just say, audience, put your questions in the chat for any of us, and we will come to them soon. But James, give us some optimism, because I'm feeling quite pessimistic at this point.
Don't you worry about that. It's a wonderful world. We're all lucky to be here. Tom alluded to something earlier, an inevitability that things will change. And whilst I joke that AI is going to come and save us all, at some point I do think it will. Beyond that, it might be an existential risk to us all, but there's a middle ground at some point in our future where I think it does save us all in healthcare, and I can explain. A myth that I was going to raise earlier and ended up asking Tom a question because I was so interested in his answer, but a myth I was going to raise earlier was that investors say you can't build a tech company with the NHS as their main customer. A lot of investors say that. And they say that because in order to get VC money, you need lots of money to get to build a product and get over regulatory hurdles and build all this stuff. So you need this huge amount of money. So you need to go to people who can give you this huge amount of money. The problem with that is that then you need a huge amount of scale, because those people that have given you a huge amount of money want a huge return on their money. And so you end up in this cycle of needing to raise lots and needing to scale lots, i.e. needing to get the same thing in pretty much every NHS trust in the country before that investor gets their money back. Now, as we develop technologically, as we go forward with AI tools, it's going so rapidly, almost weekly, daily at this point. There are advancements in the way that we build AI technology. How easy it is to actually build a product that can help is getting better. It's getting easier and easier and easier to build certain things that can help. Think how easy it is now to build a website. You'd have previously had to go to some engineer and then a WordPress expert and then this, and then now you could just do it yourself in 5 minutes. You can literally do it in 5 seconds with an AI. But it's the same thing with various elements of technology. So so the costs to bring a product to market are getting less. That means that technology entrepreneurs aren't needing to raise as much money in the future necessarily, so they don't need as much scale. Now, most people here will know that healthcare is a very local game, in that there are lots of local problems that can be solved by local solutions. Where you do have, AI stroke platforms that are clearly relevant to everyone, and yes, they do need huge amounts of money to come in, and they can fortunately scale. There are also local solutions or local problems that can be solved by local solutions, and that is going to become more common. It's going to become more common that technology in a form that we're all more used to, because we use it in all parts of everyday lives, is going to reach healthcare and reach the NHS. We just need to be in a state of mind to adopt it on the demand side, on the NHS side, which is why I talked about incentives, Henry, before, because I think this is the big one for me. This really is, because I've worked at the Health Innovation Network, I've worked at Digital Health London, I've worked in the NHS as a clinician, I've worked on the management side, I've worked at NHS England, I've worked at Health Education England, and it's been the same thing no matter what NHS organisation I've worked in, which is that I don't have an incentive to make any sort of, I'm going to call it radical change, but pretty much any change at all, really. And Tom, you talked about a voluntary group at the beginning that you lead. You talked about a separate champion individual that is so individually motivated. And it seems that in order to get change, we're having to rely on these individual beacons of light that are going so far out of their way and putting so much risk on themselves to take a bet on making change, that I think if we can do something that can change mindset, something that can change how open we are to innovating, whether that's through a financial incentive to an organization, whether that I don't know, I have thoughts, but I think if that's something that we can change as we move forward with technology and it gets cheaper to adopt, less big raises, less returns needed, more products to market, more local solutions to local problems, I think it is better on the horizon.
So we're coming to the end of our hour. So I'm going to ask a very quick question, and I want very quick answers from whoever wants to dive in. Was it a mistake to wind up NHSX and NHS Digital and to fold them into NHS England, or should they have remained separate? Yes or no, James?
Diplomatic. I don't know, because I don't know what the perceived advantage. I mean, you can guess, can't you? The perceived advantages of sitting separately, having clear focus, all of that sort of stuff. The proof's in the pudding, right? Is there more innovation now or not? Arguably, yes. I don't know. Like it's difficult to say, that one. I think that's probably, in the grand scheme of things, quite a small change in real terms compared to funding an organization that can change incentives, or funding Topple fellows that sit in every NHS trust and critically appraise tech startups from 9 to 5 every day and are able to make a sensible decision on what tech to bring in. I think there are. But your question might relate to that. Would a separate organisation be more empowered to do so versus part of the mothership? Probably. So actually, maybe my answer is it was a bad idea.
Tom, Glenda,
Burn me on the fence. Burn me on the fence, Henry.
Yes, a bad mistake, because we've demoted digital as a policy area hugely. I think at NHSX, when I was working there, we had access to ministers. The CIO for the NHS now, John Quinn, now reports to someone about 7 steps away from a minister. So I think the whole ability to look at digital sensibly in terms of policy, what should be done once for all, how do we develop standards, it was almost just starting to work at NHSX. I mean, they had COVID and stuff, and that's all gone. None of that's going anywhere as far as I can see from the outside. Then it's harder for us to know what NHSE is up to at the moment. Like, we used to know where to go for NHS digital developer pages, who to contact. As a trust, it's harder for us to engage with digital national stuff. Is my sense now, except for EPR, where they've got a good community. But yes, also something needed to be done. I used to work at NHS England. There were upwards of 10,000 people working in national roles on very attractive banding compared to local resource and frontline leaders. So something needed to be done, and I think that's what Laura Wade-Geary was getting at when she tried to fold them into each other. If you look at NHS Digital from space, you can see it's huge, and something needed to be done about that. But we've lost quite a lot in the move, I think, and I think that's going to be hard to recover.
So we're pretty much out of time. I'm going to end on a pessimistic note by saying, working with the NHS over the last decade and a half, I've so often seen teams built with access to resources who go through a process of understanding the problem and start coming up with solutions, and then they get reorganized, and the organizational knowledge in the system just vanishes over and over. That's my bugbear. Look, thanks everyone. We could go on. There's 100 more questions I could ask you, but we need to round up. Thank you very much. Thank you, audience, for attending and for your thoughts in the chat. There's some interesting side chat going on there. Thanks to Maldaba for hosting today. This concludes Maldaba's 2024 webinar series on sustainable improvement. Past videos are on YouTube. This video will be appearing on YouTube shortly. You can find the Maldaba channel on YouTube. Just search for Maldaba. There will be a 2025 webinar series announced soon. Details to come. You can sign up for a Maldaba newsletter on the Maldaba website to hear about that, or just check out their LinkedIn page. Thank you very much, panel. Thank you very much, Lorenzo, for organising everything. Here endeth the webinar.
Thanks everyone for joining us, and thanks very much to the panel, and especially to you, Henry, for chairing. Really appreciate it. I hope everyone has a restful time over the Christmas period, and let's hope 2025 is better.